Good morning. My name is Amara Azibike, and I'm the Director of Behavioral Health Advocacy and Policy at Boston Children's Hospital, and I'll be acting as your moderator and one of three panelists for today's session. On behalf of the Office of Government Relations and the Children's Mental Health Campaign, it is my privilege to welcome you to today's webinar on behavioral health boarding, children and families in crisis. We have convened this discussion in the midst of an escalating behavioral health crisis nationwide and the COVID-19 global pandemic, with the goal of turning back the curtain on this incredibly heart-wrenching challenge from our unique perspective as an acute care pediatric provider, as innovators, and as partners in advocacy. We have about 600 registered attendees for today's session. Stakeholders far and wide, including parents, clinicians, advocates, and the media, who have signed up to be a part of this discussion both today and moving forward. Before we begin, and I introduce you to our esteemed panelists, I first have the honor to welcome the CEO of Boston Children's Hospital, Sandy Fenwick, who will open today's session with a few remarks. Sandy's steady leadership in a time of great change and turmoil has been incredible for me to witness, but it is also a testament to what we can achieve when our leadership is fully engaged on the very things that matter most. Sandy Fenwick, everyone.
Thank you, Amara, and thank you all for joining today. This is a discussion that I think is so critical as we try and discuss and find solutions to this behavioral health crisis. As we navigate these challenges, I just wanted to make a few comments. First, I'm distressed that we have to have this conversation today, but I'm also heartened that so many of you have joined, 600 as Amara said, to improve the behavioral health system for children in our Commonwealth. I'm also heartened that over the past year, 2020 and now into 2021, so many people have joined the fight to not only deal with this global pandemic, but also to address all of the healthcare needs broadly for children. I also wanted to just mention that, of course, we are here today to talk about one aspect of that, the mental and behavioral health issues facing children and the growing challenge of boarding. I want to just call out a few people who have been really at the front lines of some of this issue. Clearly, our nurses, our social workers, and of course, our security guards, our physicians in the ED, our pediatricians, our psychologists and psychiatrists, all of them have been dealing with the issues of boarding in the emergency room and in the floors. They all know that this isn't the very best care that they could be given, but they are all doing their very best to do their best for these children. Yet we are really still trying to find long-term solutions, and that's why we're here today. A few words about how Boston Children's Hospital is trying to be part of the solution. Next summer, we will be adding 12 inpatient beds in our facility in Waltham. We're looking to ask and add what kinds of resources are going to be necessary to still take care of patients on the floors and in the ED. We're committed to increasing access to patients wherever they are by investing in our community, by improving services anywhere, including virtually through virtual care. We are committed to advocating as we have, and advocacy is still such an important part of this. We've been the founders of the Children's Mental Health Campaign from the beginning, and we're going to continue to advocate for behavioral health workers to ensure that we have a robust and clearly responsive, culturally sensitive and diverse set of healthcare workers. So we know that this is a problem that is not just local. It is an issue that's facing children across this country. I'm on the board of the Children's Hospital Association, and I have chaired the Public Policy Committee for the last 6 years. This has been the topic on our agenda every single meeting. And in our Public Policy Committee, we are not only looking to advocate at every level of government and across all of our administrations, but also to look for additional support and funding. And in fact, there may even be some relief in the current COVID relief package. So thank you. Thank you. We recognize that none of us can do this alone, that collaboration and partnerships is what's going to be the solution as well. And so thank you to the panelists and to all the guests who are working together, if not yet, then soon to be, working strongly arm in arm to make this a better system for the kids and the families of this Commonwealth. Thank you so much. I'm turning it back to you, Amara.
Thank you, Sandy. We really appreciate all of your hard work and engagement on this. Alexia, do you mind pulling up the slides? Thank you. So a few housekeeping notes before we get started. All questions will be addressed at the end of the session. Please type your questions into the Q&A box at any time. If you have any tech issues, please feel free to use the chat box after today's session. You will receive an email that includes the link to the recording of today's webinar and an evaluation. Next slide. So we have a great session for today. We will be hearing from Dr. Patricia Ibiziaco from Boston Children's Hospital and Nancy Scannell from MSPCC and the Children's Mental Health Campaign. The goal of this session is to provide an overview of the pediatric behavioral health boarding crisis in Massachusetts, including the impact of COVID-19 on boarding, to describe the clinical and operational role Boston Children's has played in promoting access to acute psychiatric care, and also to share advocacy efforts aimed at solving the boarding crisis. And I will be your first speaker for today. So my goal is to provide a quick overview of the boarding crisis as a foundation to the presentations that both Dr. Ibiziaco and Nancy will give in just a few moments. Over the course of this webinar, you will hear about how the children's behavioral health system is plagued by a shortage of inpatient and community-based intensive care beds. This shortage existed before the COVID-19 pandemic. However, COVID has increased the need for a responsive pediatric behavioral health system. As of today, there are currently no inpatient psych units in Western Massachusetts for children. And there's only one inpatient unit in the state that specializes in care for children with autism spectrum disorder. This specialized autism unit has struggled to remain open, and it is clear that the state needs more capacity to care for children with general acute psychiatric needs, but also for children with acute psychiatric needs that have additional complexity. The numbers show that children with complex needs board for longer periods of time. This includes children with autism, children with co-occurring medical complexity, younger children under the age of 12, and children exhibiting aggressive behavior. We are encouraged by the announcement of a few of our peers across the state who are planning to bring additional pediatric inpatient beds online. And as Sandy mentioned, Boston Children's also plans to increase our inpatient capacity at Waltham. The boarding crisis is not only a result of a shortage of inpatient care options, but it is also a result of a shortage of options across the full continuum of care. Accessing outpatient behavioral health care can be very difficult. As it stands, there is inconsistent behavioral health capacity in primary care practices, a lack of community-based urgent care options, and this sometimes results in the emergency department being the most accessible place to go. Next slide, please. And with that, I will turn it over to Dr. Patricia Ibiziaco, who is the Associate Chief for Clinical Services in the Department of Psychiatry and is also Associate Professor of Psychiatry at Harvard Medical School.
Thank you, Amara, for that introduction. As Amara mentioned, I am the Associate Chief of Clinical Services in the Department of Psychiatry, but prior to that, I was the Director of the Psychiatry Consultation Service, which provides care to patients who board in inpatient medical and surgical units, and I directed that service for 11 years. So I just wanted to take a step back and give us a 10-year perspective of how we got to where we are today. The practice of holding any patient in an emergency department, inpatient unit, or another temporary location after providers have decided that the patient requires placement and for which a bed is not available is referred to as boarding. Boarding is the term used by national organizations like the Joint Commission, but some hospitals use other terms like campers. Ultimately, what we're referring to are patients who are not in the right setting for their care. Boarding affects youth with psychiatric illness significantly more than those with medical illness. Boarding creates a multitude of stressors and problematic outcomes for children, families, healthcare providers, hospitals, and the larger healthcare system. The emergency room is an incredibly busy, hectic, and overstimulating environment. Children and families presenting in psychiatric crises have a lot of anxiety that can be worsened in the ED setting. Furthermore, the equipment used for medical interventions can pose safety risks for youth who are aggressive or suicidal. At Boston Children's, we've put in a lot of effort to make our emergency rooms safer for children who are boarding. We also have a long-standing practice of moving patients up to a medical floors after a period of time boarding in the ED. And here's what boarding on our inpatient medical and surgical floors looked like a decade ago. I'm focusing on the past decade because remarkable shifts in boarding trends have occurred during this time. There are two paths to boarding on an inpatient medical or surgical unit. The first group are patients who start the boarding process in the emergency room and then after a period of time move up to the inpatient unit. And then the other group of patients are patients who are admitted to the inpatient unit because they require medical care. For example, after a suicide attempt or because of a comorbid medical condition like diabetes occurring with aggressive behaviors. And then once those patients are medically stabilized, they start boarding to await psychiatric placement. And so while over the years there had been gradual increases in boarding, we first noticed a major bump in our volume in 2013. And there were several relevant events that occurred during that period. The Sandy Hook shooting in Newtown, Connecticut occurred in December 2012, and we were impacted regionally as schools became more vigilant and sent kids to emergency rooms to be evaluated. And children were also more anxious during that era of prominent school shootings. 4 months after Sandy Hook, we had our own major event with a Boston Marathon bombing occurring in April of 2013. And once again, we saw more kids presenting to our hospital with a lot of emotional and behavioral struggles. These were some of the presenting problems of patients who boarded in 2013. Suicidality, suicide attempts, and suicide ideation were the most common reason, followed by aggressive behaviors, and then patients with disordered eating. Unfortunately, even after the events of 2013, the boarding volumes did not return to previous levels. We continued to experience high volumes of patients requiring psychiatric hospitalizations, and we were not the only ones experiencing this. It turns out this was a phenomenon occurring throughout the country. This graph shows patients presenting with suicidal ideation and suicide attempts in 31 children's hospitals across the United States over a span of about 8 years. I'm going to spend a bit of time on this graph because there is a lot to unpack here. Before stage 4 is a term that has been used to describe the concept of prevention that originated in cancer care. A lot of effort has been done in cancer to screen, identify, and treat the illness before it gets to stage 4. And this has been so successful that providers have started using the term before stage 4 to facilitate prevention in other disorders. In child psychiatry, our version of stage 4 is a child or adolescent who is having thoughts of wanting to end their life or presenting to the hospital after trying to take their life. If you apply the before stage 4 concepts to child psychiatry and look at this graph, the implications are devastating. Imagine that rather than suicidal ideation and attempts, this graph was showing a steady rise in stage 4 cancer in children and adolescents all over the country, rising over an 8-year period. The horror and pain that image evokes should be the same when applied to children and adolescents with suicidality. And unfortunately, it's not. And it highlights the healthcare disparities experienced and stigma experienced by people suffering with mental illness and the way they are treated differently and their conditions are not taken as seriously. This is despite the fact that in 2014, the CDC reported that suicide became the second leading cause of death in teenagers. The path to suicidality cuts across almost all psychiatric disorders: depression, anxiety, psychotic disorders, personality disorders. And we have such a tremendous opportunity to intervene in children and adolescents before the pervasiveness and severity of stage 4 disease. And yet the healthcare disparity is even seen in federal funding. From 2012 to 2017, physicians, scientists, and child behavioral and developmental specialists received the lowest research funding among 18 pediatric specialties. Only 1% of R01 grants were awarded to child behavioral and developmental specialties versus 16% for pediatric hematology oncology. Now let's go back to imagining that this was a graph of children with stage 4 cancer. Imagine those children being stuck in the ED for days, unable to access the care they need. The majority of children with suicidality that you're seeing in this graph are in emergency rooms and on inpatient medical and surgical units all across the country. Imagine the fear and outrage any parent will have after hearing their child say they want to kill themselves and then bringing the child to the ER and still be unable to access timely care. Is the pain of a parent who loses a child to suicide any less than the pain of a parent who loses a child to cancer? If anything, the shame and the blame and the guilt that occurs in families with completed suicide leads to complicated grief that can last a lifetime. Now, you may be wondering, if this has been happening for years, why are we just talking about it now? Why haven't people been talking about this? Why is this information just in medical journals? Well, take a look at this. There have been articles about this problem every single year. This article, Mentally Ill Languish in Hospital Emergency Rooms, was published in 2011. This article, Broken System, How American Hospitals Are Failing Mentally Ill Kids, was published in 2014. Children in crisis waiting for days in local ERs for transfer to mental health facilities, published in 2015. If there was more room on the slide, I could have included more articles after 2015. But the underlying issue here is the stigma and healthcare disparity associated with mental illness. How we pay for care impacts how care is provided. And this healthcare disparity is reflected in the poor reimbursement for mental health treatment compared with medical and surgical treatment. And since mental health services are under reimbursed, salaries and psychiatric facilities have been underfunded. This means hospitals that try to provide psychiatric care lose money. And for those hospitals who do provide psychiatric treatment, there's further struggles with insurance companies requiring prior authorizations for urgent psychiatric admissions that they do not require for other urgent medical and surgical admissions. And this prior authorization process, which is lengthy, can sometimes take over 24 hours and adds more to the length of time a child spends boarding. So to summarize, there has been a lack of growth of psychiatric treatment programs and a reduction in behavioral health workforce during a period of significant rise in psychiatric illness and suicide rates in children and adolescents. So why has there been such an increase in the emotional and behavioral struggles of our youth? Social determinants of health are conditions related to the way people live, learn, work, and play or socialize that affect a range of healthcare risks and outcomes. And over the past decade, there have been a number of factors affecting the emotional well-being of youth in the United States and around the world. There's the rise in teenagers' use of social media. Technology and social media is undermining family relationships with decreased amount of time interacting meaningfully with each other, leading children to be more isolated and lonely. And since there are millions of other people online, teenagers are vulnerable to forming many superficial and sometimes dangerous and detrimental relationships. And it's not just online. Young people are vulnerable to media and what they see and watch on the television, cable networks, and streaming services. The 24/7 news cycle provides a constant stream of anxiety-provoking information. Movies and shows that children and adolescents watch also have an impact. In 2017, Netflix released a show called 13 Reasons Why, depicting a teenage girl who committed suicide. The show was very popular. An NIH study showed that there was a 28% increase in suicide among 10 to 17-year-old boys in the month after 13 Reasons Why was released, making it the month with the highest suicide rate out of the entire past 5-year period. Hospitals around the country reported an increase in patients presenting with suicidal ideation and attempts and symptoms linked with watching the show. Finally, after an outcry from professional psychology and psychiatry organizations, Netflix included a trigger warning on the show. Children and adolescents spend most of their time in school, and school stress and academic pressures continue to be the most common factor affecting the emotional well-being of youth. And of course, timely access to care affects many families who have individuals with mental health struggles. There is so much stigma experienced by families who have a child with an emotional or behavioral health problem. For those families who have managed to overcome the stigma to seek treatment for their child, they are unable to find providers for their child to receive outpatient care. And this is what psychiatric boarding looked like 4 years leading up to the 2020 pandemic. There was a 61% increase over 4 years. A CDC survey that was conducted in 2019 found that 1 in 3 high school students reported feeling persistently sad and hopeless. And this was a 40% increase from a decade prior in 2009. And so it is in this context of a steady rise in depression, suicidality, and psychiatric illness in children and adolescents over the preceding decade that the COVID-19 pandemic struck our world. And it affected social determinants of health with the force of a hurricane. Everything about the way we live, learn, work, play, and socialize changed rapidly. Tens of millions of students had their learning disrupted. Extracurricular activities were canceled. And aside from the impact on academics, this has also impacted physical activity. Studies are showing that adolescents have become more sedentary since the beginning of the pandemic. And this decrease in physical activity can have a negative impact on their overall well-being. For many kids with pre-existing mental health condition, their treatment has also been disrupted. Over 10% of adolescents receive some mental health services in the school setting, and this was disrupted with school closures. Perhaps one of the best outcomes of this pandemic is how rapidly the world adapted to telehealth, which has been remarkable for delivering mental health care. But not all families have access to this. Not all families have access to devices or to the internet to participate in treatment. With parents now working from home and children learning from home, families don't have enough opportunity to spend time away from each other, leading to an increase in family conflict. And then there's, of course, the economic disruption. A study published in Health Economics Journal a few years ago on the impact of the 2008 recession revealed that a 5% increase in the national unemployment rate correlated with a 35 to 50% increase in childhood mental health problems. Last year, in April of 2020, the unemployment rates increased by 10 percent points to 14.7%. This was the highest month-over-month increase in the history of the unemployment data, which goes back to 1948. By October 2020, unemployment rates had fallen to 6.9%. But this was still nearly twice the pre-pandemic unemployment rate in February of 2020. We now know that COVID-19 affects older people more than younger people. However, while the virus may have spared the bodies of our youth, it has not spared their minds. Kids are worried about the adults in their lives, their parents, their grandparents, their teachers. They're also worried about themselves. And the stress is manifesting as physical symptoms, and they are presenting with somatic and functional disorders. So what does this all mean for the data and how people are presenting during the pandemic? Just a few days ago, the Journal of JAMA, the Journal of the American Medical Association, published a study that showed a 45% decrease in admissions across 49 US pediatric hospitals between January and June of 2020. And this included a decrease in mental health admissions. I must say, though, that last year, the Journal of the American Academy of Child and Adolescent Psychiatry reviewed over 60 pre-existing studies on isolation, loneliness, and mental health in young people. They published their findings in June, and they suggested that children and adolescents are likely to experience high rates of depression and anxiety long after the pandemic lockdown and the social isolation end. They also said the impact of loneliness on mental health could last up to 9 years. We decided to look at our data with a different time frame. We looked at the 3 months of the lockdown between April and June and the 4 months after the lockdown. And what we found for patients with severe suicidality who presented to the hospital was a 25% decrease in the months of April to June and a 47% increase in the 4 months afterwards. We usually see seasonal variability in the volume of patients boarding in the summer months due to kids not being in school, but we did not have that last summer. The patients who were presenting during the pandemic were also much sicker with more severe illness. Many of these patients required medical admissions at rates that were higher due to severe suicide attempts. While our adult hospital colleagues were gearing up to create ICU capacity for an influx of patients with COVID-19, we were experiencing a different type of problem. During the first 7 months of the pandemic, between April and October of 2020, there was an 89% increase in patients requiring ICU or ICP, intensive or intermediate levels of care after severe suicide attempts compared to the same period a year before. Many of these patients were presenting after suicide attempts by ingestion or overdose of pills. Another group of vulnerable patients are patients with eating disorders. Patients with eating disorders struggle to gain control in an otherwise chaotic existence. And a pandemic during which so much is out of control regarding the virus, schooling, socializing, this has been a major stressor triggering disordered eating among adolescents. And for these patients, the picture was even more striking. Not only did we see more patients with severe eating disorders requiring hospitalizations during the lockdown period, where there was a 45% decline in all other admissions. There was a 109% increase in patients hospitalized with eating disorders in the 4-month period after the lockdown. Of note, some of the patients with eating disorders were also suicidal. I have just described 2 specific patient populations with suicidality and eating disorder just to highlight the impact of the pandemic. But there were many more patients that we've seen during this period, including patients with neurodevelopmental disorders such as autism spectrum disorders and intellectual disabilities, patients with psychosis, patients with trauma. And this is what the monthly trends of boarding look like from 2018 until December last year. You can see the steep plunge in the volume in April of 2020 during the lockdown, and then the steady and relentless rise to unprecedented levels afterwards. And there are several reasons for this. This rise does not just reflect an increase in the volume of patients. It also reflects a decrease in bed capacity in a mental health system that was already lacking in sufficient number of beds. In order to implement safe infection control protocols and to ensure social distancing, many psychiatric units had to reduce their beds or even undergo brief closures during the pandemic. Additionally, because we have been seeing patients with more severe illness, they're requiring longer hospitalizations before they're safe enough for discharge. This means longer lengths of stay at all levels of care, including inpatient psychiatric units, decreased throughput throughout the system, and therefore longer times boarding waiting for a bed. This graph ends in December of 2020 with a dip in the volume corresponding to the holidays. But I can assure you that if this graph extended to January and February, the rise in volume of patients boarding that you will see continue past this peak to new levels that we've never seen before. And this is happening all around the country. Children's hospitals in New York, DC, Colorado, Cincinnati, Missouri, Florida have all reported an increase in patients who are suicidal since the beginning of the pandemic, and also increase in boarding due to difficulties finding available inpatient psychiatric beds. And this highlights the fact that along with COVID-19, we are dealing with a mental health pandemic in a mental health system that has been working poorly for so long. Across the country, there are reports of clinician burnout and even more people leaving the workforce. Frontline behavioral health providers have been putting in heroic efforts for years. Many outpatient providers are seeing more of their patients getting sicker and requiring psychiatric hospitalizations, highlighting that even patients who have existing outpatient supports are still vulnerable. For providers working with boarding patients, the burnout rates are much higher. They are overwhelmed by the growing need in a broken system over which they have no control. They are bearing the brunt of frustrations that families and other providers have about care that is insufficient. These providers who are stretched to the limit are internalizing a constant message that they're not doing enough. And behavioral health providers of color are dealing with 3 pandemics: COVID-19, racial strife and injustice, and the related healthcare inequities, and then the mental health pandemic with its own healthcare disparities. I know this to be true because I am a face of this group. In order to safely care for our patients with mental health needs, particularly boarding patients, we also need to address the well-being of the providers involved in their care. When you think of traditional treatment and therapy sessions, you think of the time spent with the patient and with the family. But for patients who are boarding, there is a lot of care coordination with hospital staff who are not behavioral health specialists, and a lot of collateral contact and coordination with folks outside of the hospital and in the community, such as outpatient providers, schools, state agencies like the Department of Mental Health and Department of Developmental Services. We also have a terrific collaboration with our local crisis team, the BEST team, and they're an excellent resource and partner for the care for many of our patients. These components of care are necessary, and the circles are bigger because they take more time. However, those efforts are not reimbursed. The patient is at the center of these efforts, but in order for the patient to have more therapeutic time, more providers are needed to care for all of these components of care. And over the years, we have expanded our workforce to have a multidisciplinary team caring for boarding patients 7 days a week. However, patient volumes have been growing at a much faster pace than the workforce, and the pandemic has accelerated this significantly. We are in the process of expanding this workforce even further. There's a multidisciplinary effort to work on staff training and educational initiatives. We have a standardized protocol of care with daily assessments and reassessments, short-term therapeutic support, medication management, and other crisis interventions. The pandemic volumes have limited clinicians' ability to provide all of these supports, but with further expansion of the workforce, the goal is to provide even more enhanced care. In order to provide outpatient access to families before they get to stage 4 crisis, we are planning a long-term expansion of our outpatient program. We have already added outpatient services at our Waltham site, although most of the services have been conducted via telehealth during the pandemic. I should also point out, though, that children who have outpatient providers are still vulnerable to stage 4 crisis, so there will be an ongoing need for acute psychiatric services. And as has been mentioned, we are opening an inpatient unit at our Waltham site to join our 12-bed residential program that is also at our Waltham site. And in a few years, we'll be opening a partial program. This means we will have a full spectrum of psychiatric services at every level of care: outpatient, partial, residential, inpatient, and we are very grateful to our hospital leadership for the level of support that they have provided for this expansion. We also have a lot of community efforts. The Behavioral Health Integration Program is a partnership between the Department of Psychiatry and Behavioral Sciences and the Pediatric Physicians Organization at Children's, the PPOC, to provide education, consultation, clinical services, and behavioral health integration in over 80 PPOC practices in Massachusetts, caring for more than 350,000 patients. And the goal is to enhance the capacity of PCPs to safely manage mild to moderate pediatric psychiatric disorders. And to date, a 2-year educational course has been given to nearly 500 PCPs, and 75 behavioral health therapists have been integrated into PPOC practices. Our community efforts also extend to schools via the Boston Children's Neighborhood Partnership Program. BCHNP has partnered with Boston Public Schools to provide a range of on-site clinical early intervention and prevention services in 6 public schools. They have also developed a training and access program, which provides hours of consultation and online training to 10 Boston public elementary schools. And BCHNP has developed a very important Break Free from Depression training workshop in partnership with Open Pediatrics. And the training videos and workshop materials have been made available to school communities across the country. Despite all these efforts, there is so much more work that needs to be done. This crisis was over a decade in the making. Untreated mental health conditions cost the US over $100 billion a year. We need big, bold, impactful, long-term investments to develop a mental health system of care that works well for children and for families and for the providers who are delivering the care. We need to support the well-being of our clinicians, bolster our workforce, and address the disparities in mental health care. We need collaboration and coordination at all levels: federal and state agencies, private sector companies and individuals, healthcare providers, hospitals, insurance companies, all working together. We need to do a lot more work to ensure that children and adolescents with emotional and behavioral health problems can receive the right care in the right setting at the right time. It's the right thing to do. Thank you.
Thank you so much, Dr. Ibiziaco. And with that, I will introduce Nancy Scannell, Director of External Affairs at Massachusetts Society for the Prevention of Cruelty to Children. Nancy, you're on mute. Zoom.
All right. I guess I had to be the one to do that. Sorry about that. Thank you for the opportunity to be here today. And thank you, Dr. Ibiziaco, for that great presentation. The Children's Mental Health Campaign has been partnered with Boston Children's Hospital for 15 years now. Amar, if you want to go to the campaign slide. And during that period of time, we have, as Sandy Fenwick said, worked together to impact the children's behavioral health system, specifically around providing timely, effective access to care for kids in the place that they need it with the services that they need. We are incredibly grateful to Boston Children's Hospital for being there from day one with us to establish the Children's Mental Health Campaign and walking hand in hand with us on each and every day since then, both as policy partners and, as you heard, on the ground, creating services and supports to really meaningfully provide access to care for kids with behavioral health needs. The Children's Mental Health Campaign consists of our two organizations, and we are joined by the Parent Professional Advocacy League, Healthcare for All, Healthcare Advocates, and the Massachusetts Association for Mental Health. And together we comprise the leadership team of the Children's Mental Health Campaign. But we are the tip of our iceberg. We are joined by really hundreds of organizations who work with us on a variety of initiatives each and every day. So if we go to the second slide, with regard to the issue of boarding, it has been a concern of the campaign since our earliest days, and we have addressed it by looking at it systemically. As you heard, beds are a central element of the problem of boarding, but it is in many ways the canary in the coal mine that really highlights issues throughout the behavioral health system of care that we have been working together to address. And so this illustration sort of shows our view of the points in time along the way at which boarding can be addressed, hopefully averted, both as a child who is at home, has a crisis, and then needs care in the hospital, and also as they're returning to the community. So if you go to the next slide. So we began in earnest taking a look at the boarding initiative with a research project that was led by Boston Children's Hospital, where we gathered data from 10 emergency departments over the course of a year. Emerging from that was a focus on some of the special needs that Dr. Ibiziaco highlighted for you, including a particular cadre of young people who boarded the longest, who also had co-occurring autism spectrum disorder or intellectual disabilities. A couple of other groups of kids who board the longest are those who have externalizing behavior that results in aggression or, in some instances, assaultive behaviors, and that another cadre of youth who are either DCF or DYS involved. Our focus has been in a couple of different spaces. So we have been working to develop and advance best practices, including a focus on pediatric behavioral health urgent care, and most currently, really re-looking at the administrative processes for addressing barriers to access. In terms of resources, the campaign has been worked with the legislature to increase capital investments to provide hospitals with the resources that they need to stand up beds, to implement the kinds of crisis services that Dr. Ibiziaco talked about. And in addition, folks may be aware that MCPAP has added through the mobile crisis teams access to applied behavioral analysis services, and of course our support of the Bright program, which helps kids who are returning from a hospitalization, including a behavioral health hospitalization, return to their school environment successfully. In terms of policy change, among our current focus are access resolution processes. So you may be aware that at the individual level, there are folks like Amara who work daily to help untangle the complex systems that are sometimes at the heart of a person who needs a hospitalization getting access to that bed, and a focus on data. The data focus may seem a little wonky to folks, but in fact, having accurate data is going to help really guide well-informed resource planning. So as we move into this legislative session, you'll see that the campaign has a number of budget bills and other initiatives focused on the boarding crisis. I'm aware I had intended to spend a little bit more time on this, but I'm aware that folks have questions. I can see them building up. And so what I will say is that the campaign will continue to hold lunch and learns where we'll dig more specifically into some of these initiatives through the budget process and through the legislative process. And we hope that you'll join us for those. Thank you.
Thank you, Nancy. It's now time for Q&A. So panelists, can you please turn on your videos? We have got a few questions in the chat and a few questions that have come in ahead of time. So with that, I'll get started. Nancy, we got a policy question around how can state funding address the boarding crisis?
Well, the state funding can help in a number of ways. So, as I was saying in my comments, the boarding crisis can be averted both before a kid comes into an emergency department seeking care by providing them better access. And so, I referenced our work in behavioral health urgent care. In the interest of time, I didn't dig too deeply into it, but state resources can really be effective in providing services to kids when they're in school. I think, in Dr. Ibiziaco's comments, she referenced the impact of COVID-19. Among those impacts are the reality that for many kids, the primary place that they get behavioral health care is in the context of school. During the pandemic, most of those services have really not been available, both because kids are not in school or because of limitations on folks from outside, so community-based providers coming into the school to provide services. For those who have received them, they have been a vital lifeline, and Boston Children's Neighborhood Partnership Program has been a big part of those solutions in Boston and elsewhere. But that's a place to start. There are other investing in Bright, so when kids return to school, investing in really providing access to advocates who can help with some of the most complex situations that cross over multiple state agencies, and that involve really multiple legal processes for how kids access care. So there are many, many ways in which resources can be brought to bear on this, up to and including bringing resources forward to pay for the kinds of services that are not traditionally reimbursed by insurance, some of which you heard Boston Children's Hospital putting forward to the folks that are coming to receive care there, but really should be made available in every setting, in every hospital setting that kids in the Commonwealth are seeking assistance. So those are some of the ways we are working on many, many fronts at the same time. And it may seem like, well, how can you do all of that? The good news is that we're a big team. There's a lot of expertise. And we have really strong champions, both in the administration and legislature, that are working side by side to help us achieve those goals.
Thank you, Nancy. And before I get to the next question for Dr. Ibiziaco, I should mention that we have about 9 minutes left. And if we can't get to your question, we will be sure to follow up with some answers to the questions that we've received with the link to the recording and an evaluation form. So Dr. Ibiziaco, we got a question that says, is there any way I can help my child avoid going to the ED who is struggling with mental health challenges?
Yes, that is a great question. I was actually interviewed for the New York Times last fall, and I mentioned there that parents should try and seek outpatient care and get their child to see an outpatient provider to prevent their child from ending up in the emergency room. And a parent mentioned in the comments, does the good doctor know how hard it is to access outpatient care? And it was a very valid point. And so there's lots of advocacy that parents can do with their insurance companies, because the lists of therapists and psychiatrists and other providers are often outdated. And so calling up and speaking to a human and trying to push and to press to get an outpatient appointment is really important. And then also just being vigilant for all of the symptoms and changes in behavior that your child is going through, because adolescents in particular don't necessarily verbalize the stresses that they're going through. And so you need to be looking at other signs, like changes in the way they're eating and they're sleeping, them being more withdrawn, spending more time indoors, which may seem like typical teenage behavior, but might also be a red flag for things going on.
Thank you, Dr. Ibiziaco. And this next one is for Nancy. What would you say is the greatest policy barrier to addressing boarding?
Just one, huh? Well, so I do think that at the moment, the greatest policy barrier, well, it's not a policy barrier, it's resources. So at this point, I think that the commitment to addressing boarding has really unearthed all kinds of innovations, if you will, in terms of policy and processes that the state can engage in to really help people get access to services. They are not perfect. We are suggesting improvements to them in this next legislative cycle. But the reality is that we can untangle administrative processes all day long. But if there is nowhere for that child to go at the end of that process, the problem remains. I think that the planning piece of it is probably in the long term, right? It's hard to say this in a crisis moment like this. I think the boarding crisis has been described as being at epic proportions at this point. So talking about long-term planning can be really maybe cause more some of you to wonder if I have any touch with reality. But the planning process might have avoided at least the level of crisis that we're facing now. When we began this work, beds were not the issue, right? There were all sorts of other systemic issues that were really identified as being at the heart of boarding, but beds were really not our focus, with the exception of specialized beds for kids with co-occurring autism or an intellectual disability. Now, beds are a problem. The lack of sufficient supply of beds statewide occurred during that period of time. And had there been data and a planning process that was really informing on a consistent basis, we might have avoided it.
Thank you, Nancy. So Patricia, Dr. Ibiziaco, you outlined a lot of things that Children's Hospital is doing to support the boarding population. Would you say there are pieces of that that are scalable that other providers may be able to implement where they are?
The easiest and most scalable intervention is providing telehealth mental health services, because you can do that from anywhere. And that costs the least. And then, the higher up you go with regards to how more intensive the services are, like developing a partial program or a residential program, the more funding you need. And these are all feasible to do, and it's happening all over the country. But the easiest and most scalable would be to the telehealth outpatient mental health interventions. I just want to point out, somebody indicated in the chat for the parent who asked about avoiding the ED, that in lieu of taking kids to the ED, Massachusetts has emergency psychiatry services that can often be used to bypass. And sometimes you can call the local crisis team, like the BEST team, but that's only for families with Mass Health and Medicaid. But there are other community resources.
Thank you, Dr. Ibiziaco. So we have 3 minutes left. I'll try to get 2 more questions in. And as I've said, I promise we will get back to each question following the webinar. Nancy, can you describe some of the impact that the Children's Mental Health Campaign has had in the children's behavioral health space and how folks can get involved?
Well, let me start with how you get involved. So you go to childrensmentalhealthcampaign.org, and there are links there to get involved. I see that my colleague Lily Samuel posted a link in the chat. So I don't know. Can everybody see the chat, Amara? I'm not positive, but there is a link there to get involved, and to when you do that, you'll start to receive our newsletter and our action alerts. So I would say in the boarding space, our most important initiatives have really focused on the development of models of behavioral health urgent care. If you go to our website, you can see the full report on the model. We expect that that Mass Health, many of you know that Mass Health is about to release a ambulatory care roadmap, and we are anxiously anticipating the inclusion of urgent care services in that report. Some of our other initiatives have been, things as sort of wonky, if you will, and detailed, but really important, as unpacking provider networks. And so we've spent a lot of time working with the legislature and with the Division of Insurance and insurers to create new standards by which consumers, families, and adults can see much more clearly the provider networks that are available to them, and save the time of calling multiple providers who do not serve kids. So that was a big focus of our work. And then again, focused on getting kids services before they need that kind of emergency services that would bring them to the emergency department. So providing services when kids are in school, improving access to outpatient, the MCPAP program. There are a number of initiatives that the campaign has been involved with that we would help alleviate boarding. And clearly there's more to do because the crisis just remains really intense.
Thank you, Nancy. Thank you, Dr. Ibiziaco. I also want to thank everybody for joining us today. I want to thank Sandy Fenwick and Boston Children's Hospital leadership, as well as the leadership of the Children's Mental Health Campaign for helping us put this together. We really appreciate everybody for joining us today to have this important discussion. And we promise to continue this dialogue in ways more than this. So thank you and enjoy the rest of your afternoon.
Thank you.